charred beyond actually recognition for fear of recurrence. Now, this is a specimen what we have removed. On the right side is little longer, left side is short, and there was no injury to any pelvic area, though it was going down to the almost down to the perineum. So robotic actually helped us to dissect carefully without injuring the vital structures that are essential for anybody. Now this is a boy post-operatively, it's the third day, and the operative time was 130 minutes. There was no significant bleeding, good recovery, bowel sounds occurred same day, and oral diet and next day and ambulated. Drain removed on second day, discharged on third day. Now this boy came, he was 2 days back, about 2 years after his surgery. He is doing well. Actually, surprisingly, his testosterone levels have improved. We have stopped giving testosterone for him. His appearance is better. His beard and facial hair is much better to his satisfaction. And abdominal fat has actually come down. Now this is his look. There is another patient, a 45-year-old man, presented with lower abdominal pain, not much of bowel or bladder symptoms, and serum PSA was normal. Ultrasound showed 8.3 into 5.8 into 6 cm. Pelvic SOL, we are not sure where it is coming from, but the location showed that probably it could come from a prostate. The MRI showed large heterogeneous neoplasm in close relation to right lobe of the prostate, which was compressed and effaced. Coordinated biopsy of the pelvic mass showed spindle cells in bundles in myxosarcoma with moderate mitotic figures. We thought of low-grade myxosarcoma before we went in. You can see this is the mass, this is the bladder, this is a round, it looks like a cricket ball, and this is the rectum. You can see more closely here, this is bladder, this is the space for accommodation, and this is the rectum. So this large mass was causing some compression, pain, discomfort. Though we didn't have much symptom, it was a large neoplasm which could at any time turn into malignancy or cause pressure symptoms in future. So we elected to operate. You can see more closely here. In one angle it was a little longer. So we are dealing with a big tumor in the pelvis, close to the bladder and pelvis, bladder and rectum. Sorry, and he's the man. Just before we anesthetize him. Now you can see this is as soon as we entered. This is the mass. This is the mass. We have to enucleate, actually remove completely. Thinking that it's a carcinoma, we cannot leave much of residual tumor anywhere. So this is a surgical video where we have actually slowly enucleated, or you can say separated from the surrounding tissue. We are not sure how far it's going, where it is attached, from where it's arising. Simply our aim is to go around the capsule of the tumor and then try to separate as far as possible. We are not sure whether we could remove completely till the end, but fortunately for us, this has actually separated from the surrounding tissues. It was not infiltrating, probably because it was a low-grade sarcoma, which is not actually. You can see here there is a plane. There is a plane here. This tumor is below. This is the tumor, and we are actually separating here. So it was not attached to bladder. We didn't injure the bladder, nor injure the capsule of the tumor. And as we went in, you can see here, every area around the tumor we could separate. We are not sure what structure we are actually entering. When we are dissecting, we are only going close to the tumor and hoping that we are not injuring the vital structures. Now we have separated the mass. This is the final attachment that it had, and then we didn't see the rectal injury. We were very close to the rectum, but we didn't injure the rectum. We have seen that bladder and rectum both are intact. We have repeatedly checked with our finger whether going close to that. One person with finger in the rectum, and we used endoscopy for any injury to bladder at the end of the surgery. And it's fortunate that such a big tumor so close in the perineum could be removed completely without much damage to the other areas. Now, if you see, this is the tumor. We have put it in the bag. This is the tumor. Almost the bag itself was really short. It was filling completely. We didn't have a morcellator at that time. We didn't want to morcellate also. Simply we put it in the bag. This is the tumor, and this is the fluid. It's arising from the right side of the prostate. It's a myxosarcoma. What coordinated biopsy has shown is same. And it's a biphasic population, predominantly spindle cells, interspersed glands. Robotic surgery is the future of urology. Better access to deep secret organs. The last two cases what I have shown are very difficult to go by laparoscopy or open surgery because of their very in-depth, actually infiltration into the perineum, close to bladder and rectum. 3D visualization magnification have helped us. Endoreal instruments actually decrease the fatigue and pinpoint dissection is possible. And what is the future of robot urology? Everybody knows this, the single port. So just 30 seconds.
Yeah.
A small video here. Now single port robotic surgery, there is here most often we take it from the umbilicus. In the same port, the camera is coming out. We can position it in whichever angle you want, and we are only showing on the. This is a meat. We are going to cut it and then suture it to show how the dexterity of the two instruments. This is a torque effect. The joints, everywhere there is joint, so you can bend it wherever you want. The first instrument, actually we are cutting. We are cutting with the hook, diatonic hook, and later on we extend the instrument. You can see how nicely we can do. The camera is on the top, showing you the visualization. One instrument has cut it, other instrument is holding it, and then after it's cut, the instrument has to be taken out because we have to use a needle holder now. So we can change the instrument. There is no clash, there is no tightness. There is a increased comfort in the same single port. This is a needle holder. You can see it's holding the needle here, and then whatever nip we have given there is going to be sutured very comfortably without much struggling. Everybody thinks that in single port it may be difficult to suture it, but it's not so. We can do it very well, like in a laparoscopy or a multi-port instrument. So single port is enough to do, but it's more expensive compared to the standard 3-port surgical robo. It's more expensive. It's more. They say it's around about 30 crores. Actual XI and all are around 16 to 18 crores, but still time may come when the cost